Well, the challenge is that less than 5% of people with cancer are treated on a cancer clinical trial, while at the same time, there are hundreds of cancer clinical trials that are running behind because they can't find patients.
How important has social media been for you in your professional work?
Absolutely tremendously important. So that brought its own benefits of professional organizations and journals are waking up to the fact that they only have 2 to 3 seconds to capture consumer physicians' attention, and they need to deliver information as effectively as possible. I think it's good to be skeptical. I don't think it's fair to be fearful. Physicians have to be present on social media platforms. I realized my audience and the people who I were following were mostly other healthcare professionals. A dirty little secret is a lot of people will.
Social media is saving lives. If that sounds like an extreme statement, you need to listen to this conversation with Dr. Shaalan Beg. There must be few of us who've not been touched by cancer in some way. It feels like an area of medicine where there's so much work to be done. But listening to Dr. Shaalan Beg, a medical oncologist based in Texas, gave me so much hope. In this episode, he talks about just how far cancer treatment has progressed in recent years, but also the challenges that all this new medical science brings with it. He's passionate about clinical trials and the impact that they can make for medical science and for patients. But he also shared with me the challenges that mean that there's a real inequity of knowledge about and access to those trials. We talk about AI and how it can be used to support clinical decisions for better patient care. We talk about Dr. Beg's journey on social media, and he told me how vital he sees it that oncologists are using social media. I love how he shared with me some of his favorite oncologists who are using TikTok and Instagram to educate patients. And of course, we talked about the future. So here we go. Well, I'm so excited to be joined here by Dr. Shaalan Beg, medical oncologist at UT Southwestern Medical Center in Dallas, Texas. Welcome, Dr. Beg.
Thanks for having me. Really excited about having this conversation today.
Oh, great. Well, could you just tell us a little bit about your current location? What's the view from your chair?
Yeah, I am looking out of the window and I see a road which hopefully there will be no ambulances or fire trucks that come in front of me. But it's nice and sunny and it's going to get really, really hot very soon.
Ah, beautiful. Tell us something about what you do, how long have you done it, and how did you get into it?
So I'm a medical oncologist, so I care for people with cancer, and my specialty within oncology is focusing on GI cancers and pancreatic cancer specifically. So when we think about delivering the best possible care for somebody with cancer, we think about what are the novel treatments that are available so we can give someone the best chance possible to live their lives as well as possible for as long as possible. And we also need to keep our finger on the pulse in terms of clinical trials and what's coming down the pipeline for potentially new life sustaining or life saving treatments as well. So I straddle both of those worlds, the world of clinical care and clinical research, primarily focused around the GI cancer space. But when it comes to clinical trials, my interest and passion to some extent is really to focus on ways to extend clinical trial access using technology-enabled services, and to see how we can continue to evolve things in the oncology space when it comes to cancer clinical trials.
Amazing. When we listen to physicians on social media, I get such a sense that in the area of oncology, maybe above all other fields, there's so much work yet to be done.
Yeah, so there's been a lot of progress in the last 15
Mm.
years when it comes to new treatments, primarily focused on what we would collectively call immune therapy or targeted therapy. And immune therapy are cancer treatments which use our body's own immune system to attack the cancer in a more effective way. And targeted therapies are treatments that are able to exploit specific molecular changes in the cancer in order to treat that cancer more effectively. And it's a very different world when it comes to cancer treatments than what it was in the 80s and 90s when
Mm.
cancer treatment was synonymous with chemotherapy, which is still used for a lot of cancers and is still fairly effective for a lot of treatments, but is a different pillar when it comes to treatments for oncology.
So, what's for you? What's the most exciting thing that's happening in terms of advances in your field of oncology?
Most of the advances that are taking place, or we're continuing to see evolution in immune therapy and targeted therapy. For immune therapy, we are learning ways to help make the immune therapy treatments more effective against a wider spectrum of cancer, and at the same time, trying to make those treatments safer. Because one of the side effects of the immune therapy treatments is when you rev up the body's immune system, that it can start attacking normal parts of the body as well and cause side effects.
Mm.
So a lot of the innovation in that space is coming into how we can broaden our spectrum on drugs that can be impacted with immune therapy treatments and how to make them safer. And in the targeted treatments, if you would have asked me a few years ago, I thought that the targeted therapy treatment in oncology or the precision oncology space had plateaued, because I started to feel like we've found the low hanging fruit. We kind of made whatever progress we're going to make, but we're noticing now in the last 3 years specifically that there is so much potential to improve the delivery of treatments for the biomarkers that we've already discovered. So,
Hmm.
just to give you an example, we've known for decades that people with breast cancer who have a mutation, who have expression of a protein called HER2/neu, are sensitive to treatments like trastuzumab. And you have to be positive to a certain degree. Your cancer has to show that it has that specific marker for that drug to bind and then be effective. So it was an option for a segment of breast cancer patients. But as these molecules have continued to evolve, and we're seeing the development of what are known as antibody drug conjugates, we're noticing that you actually need a lesser and lesser expression of that molecule, so a much wider spectrum of people are eligible for that treatment and can derive benefit from it. So it continues to be an exciting space with a lot of evolution and a lot of innovation when it comes to cancer treatments, and it's a great time to be involved in this field.
Amazing. So, what are the kind of biggest challenges facing oncology treatment, and particularly the GI and pancreatic cancer treatment area? I guess in terms of not necessarily only the development of new medicines, but maybe there are other systemic issues. Where are the challenges? I suppose you're in the US in Texas, from a local, regional, national perspective, but perhaps globally, what are the challenges that you see?
If you ask me, I think the challenge are two. How do we allow as many people to have access to the novel and innovative clinical trials that are
Mm,
being developed? Because for a lot of people, that may be the only way they have access to those treatments is through those regimens. And the second part is, how do you keep up with the unprecedented number of new medications that are entering into the clinic?
right.
Each medication is coming in with its own sort of target population. It's coming in with new type of side effects that physicians need to be aware of. And if you've been out of training for more than 5 or 10 years, this was not part of the curriculum, and
Wow.
we need to rethink how do we train physicians to start oncologists to use these treatments in a safe and effective manner. So both of those require us to rethink the entire engagement process for trainees as
Uh-huh.
well as practicing physicians.
Wow. Let's take that. I want to come back to the question of access shortly because I think that's a really interesting one. But thinking about that, the advancement of knowledge, the new things, there's that kind of counterplay, I suppose, between or that tension between we want to advance science, we want to find new treatments and so on, but that constantly leads to this bombardment of new knowledge, not bombardment, but this awe of new knowledge. And how do physicians really keep up with that? What What do you think is the what needs to happen to address that? How do we fix that?
If we think about how that knowledge is disseminated right now,
Hmm.
in a couple of weeks, there are going to be 40,000 oncologists who are going to get together in Chicago and have
Mm.
our largest annual oncology meeting. There will be dozens of parallel sessions ongoing where the results of these trials will be disseminated. Like it's physically impossible to attend
Mm.
the sessions that are happening at the same time. Um, and there will be data that is presented there that will influence the care of people the following Monday after the meeting.
Oh wow.
There will be other discoveries that are a couple of months or a couple of years away from
Mm.
implementation. Not everybody can make it to that conference. Not everyone who's present at the conference can even digest the
Mm.
content that is being delivered.
You're turning
And
up
then
for a massive fire hose, right?
yeah, yeah, but exactly. And then even when you think about the more conventional ways of releasing clinical trial data through journal publications and press releases, it's hard to keep up with that. If I
Mm.
were to want to find the results of a specific clinical trial, there will be many trials in that space, and it can take me 15, 20 minutes to nail down the article that I'm really
Mm.
looking for. So you have other support systems that are online textbooks that are available where which synthesize data and make it as practical as possible. You have guidelines that some professional organizations are developing that take away a lot of the guesswork and present it to you on if you're in a specific treatment scenario for one of your patients. This is what the guidelines say, and then you can click the reference and take you there. So there are different ways to consume that information, both synchronously with the clinical care that we deliver and asynchronously
Mm.
with the clinical care that we deliver. And there are a lot of folks who are thinking about how we can use artificial intelligence and machine learning tools for our electronic medical records to sense what's happening
Right.
with an individual patient, what their stage, their diagnosis, how they're doing based on the note and other structured data, and come up with decision support at the point of care. So there's a lot that's happening there, but we're really still flipping through journal articles quite frequently, and
Right.
and listening to conferences, and social media is making some of that consumption different. I think um, professional organizations and journals are waking up to the fact that they only have 2 to 3 seconds to capture the consumer physician's attention, and they need to deliver information as effectively as possible. So everyone's in the process of continuously reevaluating their current modalities and see how they can be delivering that information more effectively and make it searchable
Right.
and
Yeah.
handy as
Yeah.
well.
So you're talking about a range of things from very sort of fast moving communications channels to still the traditional journals, flicking through those. So it's safe to say the traditional journal, the traditional medical congress meeting is not dead yet.
Well, during COVID, we were all questioning whether we would ever come back,
All right. Yeah.
and with the powers, with the strength that we thought it would be, that we would have, and lo and behold, we are back to the way things were before, for better, mostly, I would say. Um, and the congresses and these conferences provide a an a platform or an avenue for people to meet one another and exchange ideas. I don't think that anyone has been able to replicate that benefit, um, um,
Mm.
virtually.
Yeah.
A dirty little secret is a lot of people will go to the town where the conference is happening, listen to the sessions that's being live streamed from their hotel rooms, and step out of the hotel rooms to meet people and to hang out at the receptions and
Wow.
and the dinners. Because to me, that tells us why we're really there. Like there is little difference whether you're present in the room where the speaker is or you're watching it.
Mm.
And but to have thousands of your peers, your mentors, people you look up to, people who are seeking you out, collaborators from industry, collaborators from academia coming together, and the federal government coming together, internationally coming together,
Yeah.
is an extremely valuable circumstance. And we're noticing these professional organizations continue to reevaluate what their attendees are looking for. So, if we take the example of our oncology conference, it became apparent to them that this interaction is why people were coming together. And the last couple of years, they redesigned the floors to have more
Uh-huh.
lounge space and more plug-in for chargers, and more
Mm,
more neutral spaces for people to interact. So it's very interesting to see how uh, the conferences are continually evaluating to make sure they stay relevant and they stay up to speed with what the demands of their constituents
brilliant.
are.
Amazing. You talked a few minutes ago about the potential or actual realization potentially of artificial intelligence to support decision making among so much new information. There are people listening to this who might feel perhaps a bit fearful about AI being used in medical to support medical decisions. What would you say to them?
I think it's good to be skeptical. I don't think it's fair to be fearful.
Hmm.
It is a tool, just like there have been many tools before before AI. And we to some extent, I feel if there are some decisions that can ensure quality of care delivery and they can be automated, they should be automated.
Brilliant. Yeah.
For us to say that the clinician's judgment is always the best judgment, best decision that could be made all the time is a little delusional. It
Mm,
is there are many factors that go into play: knowledge, mindset, just time availability. That these tools can really augment the clinical care that a physician is delivering. Do I imagine clinical care completely being automated where people interact with chatbots in emergency departments? Well, maybe for some problems
mhm.
that's possible, but by and large, these are tools to help make the care that a physician is giving be more consistent, to be better,
Yeah. Great.
and to be more efficient. And that I'm only excited about and optimistic for.
So ultimately, you are talking about better patient care
Absolutely.
and potentially better outcomes.
Remains to be seen. I think
Mm,
we will notice a different set of problems that will emerge as
mm,
these tools
mm.
start being used in mainstream. As mainstream, we may see overutilization of some resources. We may see underutilization of others, for better and for worse in
Mm.
either case. And there are efforts to establish standards and guidances on these tools. I don't think anyone knows what that's going to look like. Like you probably saw the new releases of a couple of these large language models just in the
Yes.
last one
Yeah.
week that
Mhm.
were delivered. And at least for me, my understanding of what's possible has
Yes.
already changed. So um, I think we have to be careful. There should always be the opportunity for clinicians to be clinicians,
Mm.
because
Mm.
um, uh, I don't see these tools replacing that. And if there is a mindset that can happen, I think we should study that very carefully.
Yeah. Absolutely. Hi, I'm interrupting briefly so you can be first to know about a new app launching exclusively for healthcare professionals where you can track and boost the impact that you make on social media. The app is called Creation Pinpoint for Healthcare Professionals, and you can find out more about it at creationpinpoint.com. We've just opened the waitlist, so if you'd like to track the impacts you're making online and see how that compares to your healthcare professional peers, sign up at creationpinpoint.com. Can I come back to the question of access and one of the challenges you talked about in the oncology space and with new advancements happening and so on? You talked about one of the challenges being that making sure that there is. You didn't use the word health equity, but it's what I'm kind of hearing there is that sense of like equity of access to new treatments. What is it? Can you tell us a bit more about what's the challenge there as you see it?
Well, the challenge is that less than 5% of people with cancer are treated on a cancer clinical trial.
Wow.
Um, while at the same time, there are hundreds of cancer clinical trials that are running behind because they can't find patients,
Mm.
which are causing delays in the development of these drugs and completion of these trials. And it's also leading to lack of access for novel treatments from the patient's perspective. So the reason is that most of the clinical trials that are available in the United States are in large cancer programs that
Hmm.
tend to be urban, tend to serve better insured individuals, and are in mostly academic centers. Most of the patients with cancer are taken care of in the community. People want to see doctors who are within 10 minutes of where they live, or 15, 20
Hmm.
minutes of where they live. So that is one big challenge for cancer clinical trials, and that does lead to inequities, and the inequities also is, a double-edged sword, because what happens when you have inequitable access to cancer care, the people who are enrolling on the clinical trials are don't look like the may not look like the people who have the disease.
Right.
And on the flip side, you are preventing in some circumstances folks from having access to these novel treatments. And in the space of precision oncology, this is very, very well established that for probably about a year or 2 years between when the investigators know that this compound is active in a drug to the time a patient can have access to
Hmm.
to it across the space. I had a patient who had a mutation in her cancer that we identified in Dallas. Um, I found out about a trial for that mutation that was open in Houston. I found that out because the PI posted something on social media,
Uh-huh.
and I messaged that doctor from social media to say, "Hey, you still taking people for this trial?" And I sent my patient, and they've been now on that trial for more than 7 years. And
Amazing.
that's not scalable. That's not a process which is equitable.
Mm. Mm.
That's not good for the entire community.
So it relied on that chance encounter with the social media content, the PI seeing it, and so on. But let's talk about social media. You've been using social media for a long time, actually. How important has social media been for you in your professional work?
Absolutely tremendously important. I will say, when I joined social media, I thought that I was joining social media with the purpose of engaging patients and
Hmm.
people who have questions about cancer. Very quickly, I realized that, at least when it came to Twitter, which is where I was spending most of my time, my audience and the people who I was following were mostly other healthcare professionals.
Hmm.
So that brought its own benefits of networking,
Mm.
learning from other experts in the space, getting being able to discuss challenging situations, learning from others' experiences, and organizing. To be honest, there are a lot of groups that organized because we were able to find like-minded individuals
Mm.
who lived hundreds of miles away that we would never have been able to know or meet otherwise. Where, again, now we often would go to one of our oncology conferences and meet somebody physically for the first time, but we know them very well because
Right.
we know the way they talk and with how they
Yep.
think, and we've had potentially dozens of interactions between before we ever meet them physically. So
Yes.
so that's been an extremely rewarding experience for me. I find, at least the way I use it for myself, social media to not feel like work. It doesn't feel like email. It doesn't feel like something you have to do or
Mm.
checkbox. I know for some people it can, and we've been able to organize, um, and with time develop a library of conversations around pancreatic cancer
Hmm.
specifically, for people to go back and archive and look at
Mm.
discussions on certain topics, where we have not only been able to capture the thoughts of other physicians, surgeons, medical oncologists, but also opinions from nonprofits and advocacy
Mm.
organizations, and link it to resources that patients can then take back. And I have heard directly from people that who have followed me that it was a result of passively seeing these conversations that led them to reevaluate their family history and then get
Wow.
genetic testing and have tests done. So that's just one example, which
Amazing. So
means a lot
that's
to
a
me.
really powerful way that you can actually make an impact through social media, right? So you're learning, you've got the community, you're also disseminating information out to others.
Absolutely.
What advice would you give to other physicians or other healthcare professionals who are looking to grow both their knowledge and their impact on online on social media?
Physicians have to be present in social media, on social media platforms,
Mm.
whether that is an image based social media platform. I don't know what the correct phrase is
Mm.
for platforms like Instagram, or short video platforms or short messaging platforms. Now they're all kind of merging
Mm,
into
mm,
one
mm,
anyways. That I think is up to whoever and whatever one's strengths, weaknesses, or their
mm.
personalities are, but we have to be present. We saw over the last 5 years that if there is a vacuum in these spaces, that vacuum will be filled by somebody and somebody's voice.
Right.
And we would rather that those voices be ours,
Mm,
um, given our expertise in certain areas, rather than what would be, generally be labeled as
mm,
disinformation.
mhm, mhm,
Um, and that can have far-reaching consequences. It can have consequences on public health. It can have consequences on professional growth. So I think oncologists, physicians need to be present on social media. Um, we need to know what other people are thinking. We need to have an avenue to share our thoughts.
mm,
Patients are watching, and they may not be engaging, but they do look. And if you have an online persona, or online reputation, it impacts how our physicians view us when they come see us. They already know some of the things that we're going to talk about, and it
mm.
drives more confidence in them. I do feel the that physicians are increasingly getting engaged in the short video format, and I think that is extremely compelling.
Uh-huh.
It's you know the next generation, the people who are in medical school and in their training right now, they do not want, I'm sure they do not want to sit through 90 minutes of a lecture,
Mm,
when when we all know exactly what those tidbits need to be,
uh-huh.
bite-sized tidbits need to be in order to help drive their care, and it's our responsibility to deliver that to
Mm.
other professionals and our advocacy and patient groups as well.
And where do you see that being done well at the moment? That kind of short video. Who's really, who's doing that well?
I mean, there are a lot of influencers, I guess I can call them,
Mhm.
in the oncology space. Eleonora Teplinsky, Dr. Eleonora Teplinsky on Instagram and TikTok. Dr. Don Dijon on Instagram and TikTok. I think they have, over the years, um, created tremendous followings where, as new studies come out, they're able to give their um, interpretations
Mm.
about on it. And I can give you an example. There was a discussion in my home on the health effects of manicures
Uh-huh.
and what are the complications. I don't know anything about what the complications can be, or what the data is. And Dr. Chaplinsky, there was an article that had come out. Dr.
Uh-huh.
Chaplinsky had done a review specifically on that,
Oh, wow.
right at the time. There was a conversation going on in my household about it. So I can imagine
Amazing.
how often that happens with
Mm.
other individuals as well, who are health conscious, but even those who are not and just want to
Mm.
passively learn more information.
Wow. If you were starting over now in building your sort of online impact, what would you do differently?
One of the things that I have become a little more aware of and a little disappointed with is the realization that if we build our persona on a platform, we are really beholden to that platform.
Mm.
So, for example, when one social media got acquired and changed its name, and I was asking for subscription effects, it it completely changed the dynamics
Mm.
of how people engage with that content, who was present on those platforms, and right now with different platforms having different perspectives in terms of what is what they stand for, what their mission really is. It's becoming harder for me to think about one platform which is for the general population.
Mm.
Number one, and number two, we have seen in in healthcare and outside of healthcare that by relying on these platforms for our to create our following, if something happens to the platform, or if you become persona non grata on that platform, all of that
Mm.
can go away, which for professionals who are engaging on social media isn't as big of a deal, but for people where that is a much larger section of their engagement process and their business model, it really can
Mm.
impact those bits. So I am curious on what the next couple of years would look like.
Mm.
If I take the example of Dr. Eric Topol, who's a cardiologist at the Scripps Cancer Research in California. He has set up his own email list or a Substack list for
Mm.
engaging with his audience and then he owns the audience. He can take it with him if he wants to transition to a different platform. And I would imagine that more physicians will start taking that route, but
Right.
it
Yeah.
does require creation of new skill sets, which not everyone has or has the
Mm.
time to
Mm.
develop.
Wow. Amazing. It's going to be an exciting time to see where it develops as the platforms develop over the next couple of years. I look forward to watching and continuing to listen to you. Now, if people do want to listen into you, what you're sharing on social media, etc., where's the best place for people to find you online?
For right now, it's on X.
Mm-hmm.
First name, last name is my handle. So Shaalanbeg, Shaalan Beg. I have a TikTok channel, Shaalan Beg MD. I need to put some more effort in it. Hopefully, I'll be able to build that some more and kind of cross post on that and Instagram.
Fantastic.
Yeah, so
All
really
right. Look
excited
forward
to
to watching
continue the
that develop.
conversation. Thank you.
Dr. Beg, thank you so much for taking the time to talk to us today.
And thank you for having me.
This has been Better Listening for Better Health. I'm Daniel Jin. Thank you so much for listening. If you enjoyed this episode, please don't forget to follow or subscribe so you don't miss the next one. If you loved it, please tell somebody and tell me what you liked. Comment or email me at daniel@creation.co. And whatever you do, keep listening.